Okay, so you want to cut through all the noise, right?
Yeah,
You want to
yeah.
really understand something important, like how hospitals trying to give you the best care, but without getting lost in, endless jargon and reports.
Exactly.
Consider this your faster path to grasping something pretty crucial in healthcare today,
Yeah.
how organizations are using data analysis to actually improve quality and ultimately patient outcomes.
Yeah, and we've been digging into advanced data analysis and quality improvement in healthcare, which it really lays out this complex field quite clearly.
Right.
Think of it less like static data in a file cabinet and more like a dynamic tool that's actively shaping healthcare, shaping your care.
Hmm.
Our mission here is really to pull out the key insights, the actionable stuff, and maybe even some surprising ways this data revolution is changing medicine.
Okay, let's start with the sheer amount of data. It's kind of mind-boggling, isn't it?
It really is.
You've got electronic health records, EHRs,
Mm.
constant streams from patient monitors, operational numbers. It all feeds into this massive digital lake.
A huge lake, yeah. And the source material really hammers this home. For that data to be useful for making things better, it needs to be timely and maybe even more importantly, standardized.
Standardized. Why is that so critical?
Well, imagine trying to build something complex when all the parts are slightly different sizes. It wouldn't work, right?
No, definitely not.
Same with data. If it's not consistent, comparing outcomes or tracking trends becomes, well, almost impossible. That's where things like interoperable EHRs come in systems that can actually talk to each other, and standards like HL7, they create a common language.
A common language for the systems. But what about the actual medical terms? Does that need standardizing too?
Oh, absolutely. That's where terminologies like SNOMED, CT, and LONC are essential. It sounds technical, I know, but it's fundamental.
Okay.
If one place calls a condition one thing and another uses a slightly different term, how do you track it nationally? How do you compare treatments accurately? You really can't.
Right, you're comparing apples and oranges.
Exactly. These standardized terms act like unique barcodes for clinical ideas and lab tests. They make sure pneumonia means pneumonia everywhere.
Got it.
And, our source also makes it super clear that the whole analysis process depends entirely on the quality of this data underneath.
Makes sense. Garbage in, garbage out, as they say. So what are hospitals actually doing to make sure that data isn't, well, garbage?
Good question. The text points to a few key things. Automated checks catch obvious errors right away as data goes in.
Okay, like a spell check for data.
Sort of, yeah.
Yeah.
Then regular audits are crucial, digging deeper to check accuracy and make sure nothing's missing. And maybe the biggest piece is training the staff really well, minimizing those human errors when entering data in the first place. It's about building a culture where accuracy matters.
Okay, so we have this huge pile of data, and hopefully it's pretty clean, thanks to those checks and training. What's next? Who actually looks at it all?
This is where it gets really collaborative. The reading emphasizes it's not just, data scientists locked in a room somewhere. Effective analysis needs clinicians, the doctors, the nurses, people on the front lines working with the data scientists who have the tech skills, and also with quality professionals who know the improvement goals inside out.
That mix sounds important. Different perspectives.
Totally. You need that clinical context to understand what the numbers really mean for patient care.
So how does the analysis actually happen? Are there, defined stages?
Yeah, the source breaks it down generally into a couple of phases. First, there's aggregation and some preliminary analysis. This is often done by quality staff or within specific departments.
Okay.
They pull the data together, maybe put it on dashboards, use some basic stat software to get a first look.
Kind of like getting the lay of the land.
Exactly. Then comes the deeper interpretation and final analysis. This often happens in teams, like a quality council. They dig into those summaries, figure out what's really going on, and suggest improvements.
And this is where the more advanced stuff might come in.
Increasingly, yes. Things like machine learning are being used here to spot subtle patterns or even predict, say, which patients might be at higher risk for something. That's where it gets really interesting.
Yeah, predicting problems before they happen. Wow. Okay, so what are the core questions driving all this analysis? What do they fundamentally want to know?
The material lays out a pretty clear set. Things like, how are we doing on our key metrics right now? Are we hitting our targets?
Makes sense.
Are we meeting patient expectations? What are satisfaction surveys or patient-reported outcomes telling us?
Okay, the patient view.
Definitely. And are our care processes actually delivering the results they should, especially compared to best practice guidelines?
Right, are we following the playbook?
Exactly. Also, how stable are our processes? Are things predictable, or are there lots of random variations? Where do we need to dig deeper?
Hmm.
Did that improvement project we just did actually work? We need to compare the before and after data.
Crucial feedback loop.
Totally. And if we started a new process, is it performing as expected? Like, did wait times actually go down? Is it safer?
Very practical questions. So once they have these questions, how do they actually get answers from the data? Are there specific rules for doing the analysis?
Absolutely. The text stresses starting with those clear questions and picking the right metrics. So if you care about medication safety, you track medication error rates, right? Simple example.
Obvious when you put it that way.
Yeah. And the type of data matters too. Continuous data, like wait times, might need regression analysis to see what factors influence it.
Okay.
But categorical data, like infection rates, yes, no, might use chi-square tests to see if rates differ between groups. Different tools for different jobs.
So it's not just plugging numbers into a spreadsheet. What kind of tools are they using? Sounds pretty sophisticated.
It is. The modern toolkit includes powerful statistical software, think R, Python, SPSS for complex modeling.
Right.
Then visualization platforms like Tableau or Power BI are huge for creating those dashboards that make data understandable.
Seeing the trends visually.
Exactly. And for tracking process stability over time, they use statistical process control or SPC tools.
Mhm.
Control charts are a big one there.
Okay. And I guess just looking at your own numbers isn't enough, right? You need to see how you stack up against others.
Oh, absolutely critical. The source material really emphasizes comparing data against benchmarks. That means looking at your own past performance. Are we getting better or worse?
Internal trends.
Right. And also looking externally, how do we compare to national averages?
Yeah.
To the top performers, where are the gaps?
Yep.
And of course, making sure you meet regulatory benchmarks from places like the Joint Commission.
So looking inward and outward, how do they do that internal comparison, the trend analysis? What are they looking for?
Internally, control charts are key. They help spot if variation is just normal background noise or if something unusual, what they call special cause variation, is happening, like a sudden spike in infections that needs immediate investigation.
The red flags.
Exactly. Run charts are simpler visuals for trends, and they compare against their own targets like a specific readmission rate goal or patient satisfaction score.
And predictive analytics fits in here too.
Increasingly, yes, using past data to forecast future performance and maybe head off problems early.
And for looking outward, the external benchmarks, where does that comparison data come from?
There are reputable sources like CMS Hospital Compare, that's public info, or the National Database of Nursing Quality Indicators, NDNQI.
Okay.
By comparing their results to these, organizations can see where they lag and then look at what the leaders are doing, adopt best practices.
It really paints a picture of a systematic, data-driven improvement cycle.
Mm.
But healthcare is so heavily regulated. How does data analysis help with, well, just staying compliant?
Compliance is a huge piece of it, definitely. The sources highlight how crucial it is to align with standards from CMS, the Joint Commission, and also clinical guidelines from groups like the American Heart Association.
Right.
Data analysis is the tool to measure if you're meeting those standards. You track the relevant metrics, see where you're falling short, and then use data again to check if your fixes are actually working.
So it's about meeting external roles as much as internal goals?
Yeah.
When an organization starts this whole analysis process, what's the basic framework? Like who does what, how often?
The source stresses defining clear roles. Who gathers the data? Who does the initial look? Who leads deeper dives if needed?
Got it.
And setting regular timelines, monthly, quarterly, whatever makes sense, is key for timely insights. The initial analysis needs rigor, too. Check the data's accuracy, compare it to your baseline, and look for big deviations or those serious sentinel events.
Sentinel events. Those sound serious. What kinds of things trigger that more intensive analysis you mentioned?
Yeah, sentinel events are a big trigger unexpected events causing serious harm, like operating on the wrong site. That demands an immediate deep dive.
Wow, yeah.
Other triggers include major statistical flags, like a key metric suddenly going way off track or being way worse than peers. Also, failing to meet regulatory standards or identifying major safety risks, like a recurring pattern of medication errors. Those situations often involve methods like root cause analysis, RCA, or FMEA, to really get to the bottom of why it happened.
RCA and FMEA. Okay. So when they launch one of these intensive investigations, who's typically involved and what methods do they use?
This is where that multidisciplinary team really comes together. You absolutely need clinicians who know the process firsthand, data analysts for the heavy lifting on stats, and often input from various departments.
All hands on deck.
Pretty much. Method-wise, they'll still aggregate data and look at trends, but they'll often do detailed reviews of individual patient cases, especially for adverse events. And the source points to more advanced techniques coming into play here, too.
What kind of advanced techniques for the really tough problems?
Well, machine learning can sometimes find really subtle patterns in huge, complex data sets that humans might miss. And natural language processing, NLP, is getting big. It can analyze unstructured text, like doctor's notes, pulling out valuable info that's not in the neat data fields.
That's fascinating, reading the notes automatically.
Yeah.
So after all this analysis, intensive or routine, what actually happens? What changes?
The outcomes can be pretty significant. It could lead to redesigning entire workflows to make them safer or more efficient.
System changes.
Yeah, or targeted training for staff based on what the data showed was lacking, or even just reinforcing adherence to existing best practices and protocols.
Knowledge and behavior change, too. What if? What if they monitor something for ages and find no problems? That's good, right?
It is good,
That-
but they don't just, stop looking.
Okay.
The guidance is to reassess. Are we still tracking the right things? Are our data collection methods still good enough? And importantly, they document everything to show they are monitoring, which is needed for compliance.
It really is a continuous loop then. Collect, analyze, improve, reassess. Could you maybe just quickly summarize the core steps in that whole analysis process?
Sure. The sources kind of boil it down to this. Start with careful data collection on key measures, then aggregate and do an initial analysis, maybe run charts, histograms, get that overview.
Okay.
Next, deeper statistical analysis, SPC, Pareto charts maybe to understand variation, find priorities, then compare performance critically against internal history and external benchmarks.
Correct, the comparison piece.
If needed, trigger that intensive analysis for big issues. And finally, it all leads to action planning. Design changes, test them, implement them, and figure out how to measure performance going forward.
Okay, that makes sense. So they do all this work, find areas to improve. How do they share these findings effectively? How does it lead to real change?
Communication is absolutely key. The source mentions regular reporting to the top. The governing board needs quarterly or annual updates on big events, quality projects, outcomes.
Keeping leadership informed.
Crucial. And equally important is sharing with staff through meetings, updates, so everyone knows what's going on and can be part of the solution.
And I assume there are strict rules about privacy when sharing this data.
Oh, absolutely paramount. Protecting patient confidentiality and often practitioner identity too, especially in peer review or when dealing with potential compensation events, is non-negotiable.
Right.
The source also notes some newer trends in sharing info.
Like what? How is reporting evolving?
Real-time dashboards are becoming more common, gives people instant visibility, and automated reporting helps too. It boosts transparency inside the organization and allows for quicker responses.
Faster feedback loops.
Exactly. And importantly, this quality data shouldn't live in a silo. It needs to feed into the organization's main strategy, its risk management plans, even its financial planning, because poor quality costs money.
Makes total sense. Quality has to be woven into everything. Now, we hear a lot about transparency in healthcare. How does data analysis feed into that?
Well, transparency, as the sources define it, is about publicly reporting costs and quality metrics. The idea is to empower you, the patient, to make better choices, and also to encourage providers to compete on quality. There was a health affairs study mentioned that suggested transparency can help reduce price variations and push quality up.
But it sounds tricky. Are there challenges in making this complex data truly transparent and useful for regular people?
Oh, definitely. Big challenges. Engaging consumers is one. Understanding these metrics isn't always easy.
Yeah, I can see that.
Data consistency is another. If everyone reports differently, comparisons are hard. And balancing transparency with protecting patient privacy is always a tightrope walk.
So how are they trying to make transparency work better?
The source suggests things like using consumer-friendly formats, star ratings, clear infographics.
Visuals help.
Yeah. Standardizing the metrics everyone reports is vital. And using digital platforms to make the data easily accessible.
Okay. This whole system relies heavily on the people doing the work day to day.
Yeah.
What's the specific role of the quality professional in all this?
They are absolutely pivotal. The texts emphasize their job in ensuring data accuracy, keeping up with reporting roles, and fostering that non-punitive culture where people feel safe reporting issues.
creating a safe space for data.
Exactly. They advocate for process changes based on the data and often manage participation in voluntary quality reporting programs. There's even mention of new guidelines looking at how AI might help quality pros work smarter.
Interesting. Lastly, let's touch on public reporting and accountability. Those hospital report cards we see, how do they work and what effect do they have?
Those report cards, like from CMS Hospital Compare or the Leapfrog Group, make performance data public. The sources stress that standardized metrics are essential for these to be fair and useful.
So everyone's measured the same way.
Ideally, yes. And this public feedback loop can be a real motivator for hospitals to improve. Newer initiatives, like CMS's upcoming star ratings, are focusing more on things patients care about directly, like equity and access.
Reflecting patient priorities more.
Exactly.
So, wrapping this up, it really feels like data analysis isn't just part of quality improvement in healthcare anymore. It's foundational. It touches everything from daily routines to big strategies to public perception.
That's a perfect summary. It's this combination of a structured approach, collaboration between different experts, and using technology smartly. It's all aimed at meeting requirements, sure, but more fundamentally at driving better and safer care for patients. It's a constant cycle.
It really makes you think about all that work happening behind the scenes, doesn't it? All that data being crunched, ultimately shaping your own experiences with doctors and hospitals. Definitely leaves you pondering about the transparency and accountability of it all. Something to consider next time you interact with the healthcare system.